Thank you, Catherine, and thank you for the invite today as well to speak. It's a real pleasure to be here. It's a great pleasure as well to share a stage with yourselves, with Joe and Kelly as well, who, working in this area, people that are leading the field in this area. So it's a real pleasure for me. That's sunny Waterford. It's always that sunny as well, even this morning. And that's where the South East Technological University is, formerly WIT, but now SETU. And I don't have any conflicts of interest to declare in this topic area, but I am a lecturer in physicivity and health behaviour research in SETU. And I have various teaching and course leading responsibilities, and I'm also a researcher in this area around physicivity and what I call hard to reach populations. And of course today's topic is around most severe and enduring mental illness. So just briefly, look, I don't need to explain to you the situation. Particularly I'm focusing in on physical activity, but we don't have great global evidence. The best attempt to bring the evidence together, I know Joe was probably involved in that, is that meta-analysis going back as far as 2017, looking at physicivity levels, and no one is surprised to hear that physicivity levels among this population globally are quite low. Looking at the Irish population, and my talk will very much focus on the Irish context and the mental health services in Ireland. We tried to look at this issue as well, just to see where we are in an Irish context. Now, granted, it's self-report, subjective-based measures of physicivity in this study of over more than 100 people in rehab and recovery services, so very much focused on populations with severe enduring mental illness. But we see, high levels of physical inactivity, of course, in this population, and this was mentioned earlier. I've forgotten this lady's name. Pardon? Mairead. By Mairead. So high levels, you're talking over 70% not meeting the physicivity guidelines by a self-report. Now, it's actually probably underestimating the true extent of the issue. So we've done a little, and there is some research around objectively based measures of physicivity in this population. We tried to look at this as well, just to give context and put the context back, comparing it against the work of that meta-analysis. And really what comes out of it really, as much as the physical inactivity, and Catherine has mentioned, it is actually the sedentary behaviour as well. You're talking about high rates of sedentary behaviour. So there might be, in some HSE context, a physicivity initiative that people can get involved with, but outside of that, then you're talking about 8, 9, 10 hours of sedentary behaviour a day, and that's something that we saw in research that we've done, not published. And that would compare against the international literature as well. So high level of sedentary behaviour that we would see. So look, in the Irish context, and I've written on this or tried to be critical of this, a vision for change in 2006, very little to address physical health within the national policy in Ireland. Now, things have improved with sharing a vision, but I think there's still work to go there in the context of the strength of the evidence and the focus. As Joe, as Catherine has said, we're talking about the leading cause of early mortality in this population. So the strength of the focus is perhaps not reflected in our mental health policy, maybe, in my opinion. So there's work to be done there. In terms of services, in Ireland, delivering on physicivity or implementing physicivity in their services, they do have some resources. They do have mental health commissions, Regulation 9, particularly around recreation activities. So that's impetus there for services to engage in physicivity. And there is some guidelines. Julie Broderick and colleagues produced some guidelines around physicivity in the Irish services. But again, it's very much what I would call working at the interpersonal level and interpersonal levels, which I'll talk about in a little bit later on. But there's impetus, but then as Mairead. I don't know why that's not staying with Mairead, apologies. As Mairead is saying, where do you go from there? What do you do on Monday morning when you come into work? How do you use those? And that's where the problem is. So we can't also neglect the fact as well that at the personal level, and I think Jackie Hargreaves, and we've done some work on this as well, there are huge personal barriers to engaging in physicivity that we all have to acknowledge as well if you have a severe mental illness. That goes without saying. But then when we talk to service providers and we look at things beyond the personal and the interpersonal level, we see things around the built environment in our services as well, which become a huge problem. So you're talking, in some cases, old buildings. There's St. Daughtrin's in Waterford, and they've tried to create some recreational space out of an old church. But then even within our new built facilities, for example, in Wexford have rarely been built with visitivity in mind or consideration of how visitivity could be enabled through the built environment. And then further as well, even in talking to service providers, and this is mentioned by a few people today, and we'll talk, it goes back to that EPA guidance and Joe's message of delivered by someone who's an expert in visitivity. We have this issue as well around perceptions of risk with visitivity, a concern of how do I prescribe visitivity or how do I advise on visitivity if I haven't got the training or the expertise, or if I haven't got someone that I can advise someone else go and speak to. So we've got all these issues that we've looked at. Earlier work, I'm not terribly keen on the word obesogenic environment, but this being described as an obesogenic environment in previous literature as well, and looking at, this is our mental health services. And I'm going to speak about this project that we've done in Wexford Mental Health Services where we embedded an exercise practitioner in services. That's actually a novel thing in Ireland, by the way. It's not in other contexts, but it is in Ireland. And you can see here Anna, our exercise practitioner, working with clients with COVID, obviously, being in the context. And what you have is working in an environment that's not conducive to supporting visitivity and exercise. So that's a problem. So this project, as I said, it was funded by Sláinte Care. We kind of wanted to grasp the nettle and go, well, why in HSE Mental Health Services do we not have exercise or the capacity for exercise practitioners to work in services? As per our colleagues in the UK have it in some cases, and globally that is the case as well. So we tried to address that. So using Sláinte Care funding, we undertook this. We only had, when we started off the pilot, we only had room for one exercise practitioner. And then for the sake of equity, because much like what Catherine and Tara have tried to do, we brought a multi-stakeholder group together. And then for the sake of equity, we had to have the person work across rehab and recovery, community, CAMS, psych later life. So the person was stretched way too thin, which came out in the evaluation. But anyway, and we formed a multi-agency steering group, which I'll talk about the importance of that. And we developed the operating procedures, the protocols, the agreements. There was a challenge with actually having the HSE hire an exercise professional. So we had to hire them through the local sports partners, Sports Active Wexford. And then this working group, the steering group, developed the agreements and the procedures for the person to actually work as part of the multidisciplinary team, to have input to multidisciplinary care meetings, to review patient notes, etc. So that was the work of the steering group. That's available for anyone who wants it as well. You can have that information. We're more than happy to share for the good of the cause, let's say. And the practitioner, Anna, she delivered 8 weeks interventions, multi-component physical activity interventions. COVID impacted the multiple blocks, so there was telehealth interventions delivered as well as part of that. And we in SETU evaluated the work using REAIM. So overall, the course of the project, we see 46 service users completing 8 weeks of visitivity intervention. So good. Look, you won't be surprised to learn the outcomes. I'll just fly through it because I'm watching the clock. But increased physical activity levels across the board. So using the SIMPAC. So there's some nuanced lessons in this that are important to take forward for further projects in Ireland as well, such as what outcome measures to focus on, what's potentially going to change, and what are the measures that will actually be sensitive enough to detect changes as well. So for example, SIMPAC tool is designed specifically for people with mental health problems, as opposed to more general population monitoring of physical activity, such as like IPAC tools. So physical activity and sedentary behaviour changed, improved, and mood and well-being scores improved as well at a significant level across the people that took part. Okay, granted, it was not a randomised control trial, but it's that said, we saw very good quantitative outcomes in our data. We also, part of this as well, this is about grasping the nettle with this project and actually embedding exercise practitioners in HSE services. So we wanted to understand process outcomes as well, and other factors that are important to the process. So for example, looking at some of the kind of hidden outcomes as well, we see what, for example, service users that were not engaging with traditional services that were available. Through physical activity, we were providing gateway therapeutic access to different services. So they were starting to have conversations that were creating connections with other mental health service providers. We see, obviously, increased motivation for visitivity, increased confidence around visitivity, and that's a big thing, actually, in a lot of ways. When you're talking about someone who mightn't have exercised for years or exercised at all, and starting to engage with community-based resources around physicality, but having the confidence to actually approach it. So having the support at the initial stage of physicality, and then being able to actually autonomously drive physicality themselves in a community setting is a huge thing as well for sustaining and maintaining physicality. There are some fundamental things that help this. Having key champions on the ground is a great thing. So having the HSE involved in Aclú as well is going to be very, very important. You need champions on the ground. You do need people that are going to drive this. You need energy. You also need management buy-in and consultant level buy-in as well. That was a big factor. And look, when you change the way things are, or you change the norm, you start to shift the paradigm, as I think was said earlier. People do have, fear around risk and fear around how this might impact them or so on. So there is work to be done in about engaging multidisciplinary teams involved, bringing them along in the process too, and those are lessons that we learned too. And coming back then to the technology piece as well. A lot of what we found with that, because we had to go online for 2 of the blocks with the physicality intervention, using Zoom and WhatsApp to deliver health coaching and physicality exercise in one-to-one. And young people actually really, really adapted very, very nicely and engaged with it perfectly. And we found that young people actually really enjoyed the online intervention. There was, as was mentioned earlier, some challenges to be overcome with some of the people in rehabilitation and recovery services where they didn't have a phone, or they didn't have a phone that was had the capacity to go online. Look, that's a very busy slide, so I'll just kind of quickly summarize some of the kind of recommendations there. The multi-agency approach was key to this, having the steering group working together, bringing together heads from different places, and looking at, what are the outcomes that we need to look at, what is actually likely to change as well. And if you want sustainability of funding, you want to focus on the outcomes that are going to actually move through exercise, through the work of Kelly and Joe in laying down the evidence early on. Preparation of the multidisciplinary teams as well. As we said, if you're going to go into multidisciplinary mental health teams, you need to work with them and bring them along in the process as well. The champions, the management. There are processes, and we've looked at these as well in terms of if you're trying to use an exercise practitioner as well around referral and things like that we have developed. As well, look, this obviously we're based. A lot of this work was based in rehab and recovery, and also other clinical settings as well. But it is important that there's a community focus and a community level engagement to it as well, and that you're supporting people to be physically active in the community. I'm nearly there. Stay with me. So just some take-home things as well. As I said, it's about, and this is one of the strengths, I think, of Aclú as well. It's empowering and mobilising individuals, bringing them together, engaging the key stakeholders that are involved in this process. That's how we move people. That's how we move the process. This is a process. I talked about grasping the nettle earlier, but we are making strides. We have made strides in the last 5-10 years. The piece around co-design work, which we've done some work on, is very important, because if we look at promoting physicality, we do need to approach it from a multi-level approach. And the co-design is very, very effective for making small nuanced changes at a local contextual level. That's really, really important for physicality interventions, particularly about people who, as I mentioned earlier, at a personal level, have a number of challenges to overcome with engaging this. And as experts or as clinicians, we assume sometimes we know what people are experiencing with the likes of a physicality intervention, but we actually don't know what it looks like. And Glenn Robert won't mind me using a picture from his book, because this is a piece we did around experience-based co-design for physicality development. We don't know what it's like until we've been on the other side of the fence, and we may never be on the other side of the fence. And something as simple as, and it was brought up in some of the earlier work with this project, was I don't want to arrive to a recreational centre in public on a big bus with a disability sticker on the front of it. That's stigmatising for me. There has to be another way. So these are sometimes conceptions that we have around physicality implementation that we haven't thought about fully from the perspective of the service user. So that co-design piece is really, really important, and it's a credit to Aclú as well to be looking at that. Engaging external partners as well, bringing in new ideas from the outside is very, very important. And look, as well, I talked about the national base. I've talked about the dearth of visibility evidence for mental health in the national context. Hopefully this project will help to drive some more evidence around that, and we can start to build a picture, because that's fundamentally how we get ongoing funding for this area, is to drive evidence in the field. The infrastructure in the built environment, that's going to be a slow process. But look, if we're going to really tackle visibility and exercise and provide that as part of routine care in HSE services, we're going to have to look at that. And that I'm talking about retro building or retrofitting buildings, but also about, we need to be part of the conversation with new developments as well. And there are plenty of new developments happening nationally. We need to be bringing visibility to the agenda of that as well. And look, it's another piece, the exercise professional side of things, working in services, but our third level institutions need to run with this and look at how we kind of build accreditation around mental health and prescribing exercise for mental health populations as well. So there are avenues. Oh, that's the exercise garden colleagues and I worked on in Escorty. So we put a small activity garden. So that's just kind of emphasising the point about let's look at the built environment too and make physical activity a norm in our services. And look, this is not novel to the international world, but in a lot of HSE services, this is some stuff that we have some catch up to do. Joe, I'm 1 minute over time. But I would like to acknowledge a few people as well that I would do a lot of work with that, it's part of a team. Suzanne Deneve, Michael Harrison, colleagues in HSE services, Sports Active Wexford as well, and of course the Aclú team. Sorry, Tara, I haven't got your name on it there, but as well for your accommodation and the invite today as well. And that's Waterford at Night to close the service or the speak. Thank you.